Bill Claxton is our next presenter from CNETS Singapore.
I wanted to just take a couple of moments to share about the importance of advocacy early on as opposed to waiting much later. And in CNETS, we're a small group. Actually, I personally interact with most of the newly diagnosed patients. But the patients that we're serving are coming from throughout ASEAN region, Southeast Asia. So these patients will sometimes reach out through email or by Skype first, so we get to know something about the case, and then I meet them when they come to Singapore. And we can offer most of the treatments. Lanreotide is only just now being introduced. The costs are relatively low, particularly compared to the prices in the US. The way subsidy works in Singapore is that citizens pay about 90% of total cost. Permanent residents like me, foreigners who are working there under permit, pay about 50% of the cost. They receive the other 50% in subsidy. And then those who just come in from Indonesia or Thailand or other country visiting for medical care pay the full price. A specific case I want to share with you is a patient who came from Thailand. They were diagnosed with a thymic primary, which was large and judged as inoperable. And the gallium scan came back positive with low SUV. So it wasn't a particularly good candidate for PRRT. There was a high uptake on FDG PET, and Ki67 came back at about 15%. This patient had seen various physicians, and one of them was looking through the serum reports and noticed the CD117 stain, which occurs in about a third of the thymic primaries. And so this patient has been prescribed Gleevec, which is kind of unusual for our neuroendocrine tumor patients. And the reason I'm bringing this up as a case of advocacy is they wouldn't have come to Singapore if not for CNETS, and they wouldn't have met these 3 or 4 different physicians unless we had done the referrals. We have other unusual cases. We had one recently, mammary neuroendocrine carcinoma. So although me as a patient, I'm a midgut, so I'm most familiar with this, and then later I become familiar with PNETs because we see so many of them, and then we have our lung nets. So gradually I get exposed to more and more, but this one just came out of left field. I don't even know if this is a real diagnosis, but the medical report says that they're a mammary neuroendocrine carcinoma. Another, we have our first familial where we're treating the father and now the daughter has come. And this is a surprise to me because you see in the literature about these cases, but to see one face-to-face where they're both living patients come to the advocate for support and help. It brings up the whole issue around how we talk to our other patients about genetic inheritance. And this is not a men type case. This is just a sort of wild type, like what they're studying at NIH under Dr. Wank's group. We have a NEC carcinoma, KIC67 of almost 100%, which is the highest I've seen. The gentleman had a very good pension, but he couldn't afford private care. So in the public system, he was getting a standard regime, and it probably wasn't helping. He approached through our group, consultation in the private sector, and he realized that the treatment was probably better, but he couldn't afford it. So he went back to the public care, and sadly he's passed on after about 3 months after he contacted us. We have an appendiceal net in follow-up, and everything seems to be good, but they're not seeing any specialist. This is a very unusual one where the patient was from the Middle East, and they wrote to us and they gave all the medical reports, and I looked at it and it was like not a case because there's nothing going on currently. They were diagnosed 8 or 10 years ago. But the reason they come to the patient group is because they're just seeing ordinary physicians and they don't know whether they're really getting the right information. So these are my conclusions. We're only advocate, we're not physician, but we have to be willing to encourage a patient to get multiple consultation, and that means they have to be able to carry their CDs and medical records around with them, so we have to teach them to be an e-patient. And we have to escalate to the tumor board if required. So we have the power, at least in our group, to fast track them into the tumor board, but we have to assemble all the information. What the nurse might normally be doing, we're doing. And we have to help the patient to synthesize the results effectively before going on the treatment journey. They're going to pay a lot more for the treatment than for the diagnosis, so we always encourage lots of consultation. And you know this diagram that Larry Voles has created, it shows the patient at the center of all these specialists and talk about patient-centered medicine. I believe it's something of a misnomer because the patient is usually not in a mental state to manage their care and synthesize all this information. Typically, we place the caregiver at the center. More so, we find them a coach. A general oncologist, medical oncologist is in a good position to be the coach of the team. So I want to debunk that a little bit, but that's my last slide. Thank you.